This recording will go over assessment, analysis, planning, and implementation for sepsis and septic shock. Sepsis and septic shock differ from other types of shock in many ways. The entire syndrome may occur over many hours to days, and the signs and symptoms are less obvious. The chance for recovery is good when the patient is recognized as having sepsis with SIRS and appropriate interventions are started within 6 hours. Septic shock, on the other hand, has a rapid downhill course, and chances for recovery are relatively poor. Age is important because sepsis develops more easily among older, debilitated patients who have reduced immunity. Please review the chart that lists risk factors for shock for the older adult. Make sure to ask about the patient's medical history, including any chronic conditions that may lead to sepsis, and also drug history. A drug regimen may also indicate a disorder or problem that can contribute to sepsis, such as drugs that include aspirin, corticosteroids, antibiotics, or cancer drugs. Signs and symptoms of sepsis and septic shock occur over many hours, and some change during the progression. See Table 37-3, which is sepsis with systematic inflammatory response syndrome or SIRS criteria, for a listing of specific symptoms and laboratory changes that often occur with sepsis and septic shock. Cardiovascular changes differ in the stages of sepsis and septic shock. Cardiac output and blood pressure are low in early sepsis and very low in septic shock. In severe sepsis, cardiac output is higher, as are heart rate and blood pressure, although this is an indication of a worsening condition rather than an improvement. Increased cardiac output is reflected by tachycardia, increased stroke volume, and a normal systolic pressure and a normal central venous pressure. Increased cardiac output and vasodilation make the skin color appear normal with pink mucous membranes, and the skin is warm to the touch. This situation is temporary, and eventually the cardiac output is greatly reduced. With progression, disseminated intravascular coagulation, or DIC, occurs as a result of excessive clotting, with formation of thousands of small clots in the tiny capillaries of the liver, kidney, brain, spleen, and heart. DIC reduces perfusion and gas exchange and decreases oxygen saturation, causing widespread hypoxia and ischemia. The large number of small clots use up all the clotting factors and fibrinogen faster than they can be produced, and this leads to hemorrhage. Coupled with continued capillary leak, bleeding causes hypovolemia and a dramatic decrease in cardiac output, blood pressure, and pulse pressure. Respiratory changes are first caused by compensatory mechanisms that try to maintain oxygenation with a rate increase. The lungs are susceptible to damage, and the complication of acute respiratory distress syndrome, or ARDS, may occur in septic shock. ARDS and septic shock is caused by the continued systemic inflammatory response syndrome, increasing the formation of oxygen-free radicals which damage lung cells. ARDS in a patient with septic shock has a high mortality rate. Skin changes differ at different stages of sepsis. In the hyperdynamic stage, the skin is warm with no cyanosis. With progression to septic shock and compromised circulation, it is cool and clammy with pallor, mottling, or cyanosis. In DIC, petechia and ecchymosis can occur anywhere. Blood may ooze from the gums or other mucous membranes and venipuncture sites and around IV catheters. A kidney and urinary change of low urine output compared with fluid intake indicates shock. When a patient who has no known kidney problems suddenly starts having low urine output, be suspicious of severe sepsis or septic shock. Reduced output is caused by low circulating volume and hormonal changes. Kidney function decreases and serum creatinine levels increase. Another indicator that patients may be in the beginning of severe sepsis is often a change in affect or behavior. They may seem just slightly different in their reactions to greetings, comments, or jokes. They may be less patient than usual or act restless or fidgety. No single laboratory test confirms the presence of sepsis and septic shock, although hallmarks of sepsis are a rising serum procalcitonin level, an increased serum lactate level, a normal or low total white blood cell count, and a decreasing segmented neutrophil level with a rising band neutrophil level, also known as a left shift. The presence of bacteria in the blood supports the diagnosis of sepsis, although this finding may not be present. Blood cultures should be taken before any antibiotic therapy is started, provided that this action does not delay antibiotic therapy by more than 45 minutes. H&H levels usually do not change until late in septic shock. At that point, the hematocrit and hemoglobin levels, fibrinogen levels, and platelet count are low from DIC. The serum lactate level is above normal, and the serum bicarb levels are lower than normal. Unfortunately, these parameters may take time to change and cannot be relied on as sensitive indicators of the patient's worsening condition. Another indicator of sepsis and septic shock is a low blood level of activated protein C. Protein C is an enzyme that prevents inappropriate clot formation. It is activated when it binds to healthy vascular endothelial cells. In severe sepsis, the injured endothelial cells cannot activate protein C, and thousands of small clots form the capillaries of vascular organs. Because the results of blood cultures may not be available until the patient's condition has progressed to severe sepsis or septic shock, other biomarkers for sepsis and SIRS are needed. Two such markers are increasing lactic acid levels and increasing procalcitonin levels. The actual diagnosis of sepsis is difficult to make, yet the best outcome depends on early diagnosis and the implementation of appropriate aggressive interventions within 6 hours. Priority problems for patients with sepsis and septic shock are widespread infection and potential for myocardial dysfunction. Another priority problem for patients with septic shock is potential for multiple organ dysfunction syndrome, or MODS. With appropriate interventions, the patient with sepsis or septic shock is expected to have normal aerobic cellular metabolisms. Indicators include arterial blood gases within the normal range, maintenance of urine output of at least 20 mL per hour, maintenance of mean arterial blood pressure within 10 millimeters of mercury of baseline, and absence of multiple organ dysfunction syndrome, also known as MODS. Interventions for sepsis and septic shock focus on identifying the problems as early as possible, correcting the condition causing it, and preventing complications. The use of a sepsis resuscitation bundle for treatment of sepsis within 6 hours is the standard of practice. A bundle is a group of 2 or more specific interventions that have been shown to be effective when applied together or in sequence. Please review Table 37-5, which is the bundle for resuscitation and management of severe sepsis. You can see in that table that within the first 3 hours of suspecting severe sepsis, 4 things should occur. We should get a serum lactate level, obtain blood cultures before administering antibiotics, administer broad-spectrum antibiotics, and administer 30 mL per kilogram of crystalloids IV for hypotension or lactate greater than or equal to 4. With the IV fluids, normally when this patient comes in, we're going to get 2 IVs in them, preferably large bore, so that we can get those fluids in them to help get their blood pressure up. Within 6 hours of initial indications of suspected septic shock, administered prescribed vasopressors for hypotension that does not respond to initial fluid resuscitation measures to maintain a mean arterial pressure greater than 65. If arterial hypertension persists despite initial fluid volume resuscitation, or lactate remains greater than or equal to 4, reassess volume status and tissue perfusion and document findings. Remeasure lactate level if initial value was elevated. And you can go on and review the rest of that table, but that sepsis bundle is important to be familiar with. Oxygen therapy is useful whenever poor tissue perfusion and poor gas exchange are present. The patient with septic shock is more likely to be mechanically ventilated. Drug therapy to enhance cardiac output and restore vascular volume is essentially the same as that used in hypovolemic shock. In addition, drug therapy is needed to combat sepsis, adrenal insufficiency, hyperglycemia, and clotting problems. Although septic shock can be caused by any organism, the most common agents are gram-negative bacteria. IV antibiotics with known activity against gram-negative bacteria are given before organisms are identified, preferably within 1 hour of sepsis diagnosis. Multiple antibiotics with broad-spectrum activity are prescribed based on the site of infection and the most common geographic infections until the actual causative organism is known. The stress of severe sepsis can cause adrenal insufficiency, Adrenal support may involve providing the patient with low-dose corticosteroids during the treatment. And you know that your steroids are in the Zone and Solone, so you can recognize those. Patients with sepsis or septic shock usually have elevated blood glucose levels greater than 180, which is associated with a poor outcome. Insulin therapy is used to maintain blood glucose level between 110 and 150. Keeping the blood glucose level below 110 is associated with increased mortality. So during severe sepsis, patients have microvascular abnormalities and form many small clots. Heparin therapy with fractionated heparin is used to limit inappropriate clotting and prevent the excessive consumption of clotting factors that leads to DIC. Blood replacement therapy is used when poor clotting with hemorrhage occurs and may include clotting factors, platelets, fresh frozen plasma, or packed red blood cells. Please review the care coordination and transition management section on your own.